we will start our panel discussion. And I have several questions. Here, showed on screen is the settled question. Whether CD5 negative can diagnose CLL. Actually, according to the IWCLL, we don't have a typical CLL now. So actually, recently there's some publication from Duke University. It was reported CD5 low expression might have a fast progression of CLL patients. So the further investigation showed CD5 is very important in the BTK activity. So we really want to know what do you comments about the CD5 expression of the CLL diagnosis.
Well, this is Davide Rossi. Good afternoon, everybody. Can you hear me? Just to double check. Hello? Okay. So maybe I can start addressing this question. Actually, when I'm dealing with a sample or a case where I have a suspicion of CLL, but clinical suspicion of CLL, but CD5 is not expressed, it's the only phenotypic attribute that is not expressed compared to the others that define the CLL score at the phenotypic level. I go a bit deeper with the diagnostics. In particular, I try to fully rule out marginal zone lymphoma. For example, I'm going to ask LEF1 expression, which is 70% accurate in differentiating CLL from other indolent B-cell tumors. This has to be done in a bone marrow biopsy because this is immunohistochemistry. Then I also ask a bit more detail about the cytogenetics, because there are some cytogenetic features that, although not absolutely, but are pretty clustered with the CLL from one side and marginal zone lymphoma from the other, like for example, deletion 3214, which is recurrent in CLL, and 70 deletion instead, which is recurrent in explaining marginal zone lymphoma. This is my attitude in order to have a better overview of these cases with an atypical phenotype more in general.
Shall I start or continue? I would strongly agree with Davide and say that the term atypical CLL is extremely rare. If you really do everything to rule out other malignancies, and I only like to refer to CD5 negative CLL if, for example, I have a typical cytogenetic feature, for example, a trisomy 12, or something that is really reminiscent of CLL, and then we can call it atypical. For all other instances, we are always suspicious of a not classifiable indolent small lymphocytic lymphoma, which may be atypical, but I don't see those cases very often, because once you start doing all the cytogenetics and sequencing of mutations, is eventually you discover additional aberrations that can allow you to clearly classify it as another lymphoma or CLL in most cases. So it's a really rare condition.
If I could probably add also, I agree entirely, and maybe a biopsy of tissue is useful in that setting. But the other two aspects are that when with the atypical immunophenotypes, obviously many of the atypical immunophenotypes are CD5 positive. You have to consider whether you're if you're using MRD to guide therapy, whether MRD tests are effective when there's a very atypical immunophenotype. So you can be fooled into thinking that a case is negative MRD when it's actually not, because the markers are not typical. And then just from our healthcare system, sometimes drugs are funded for CLL and not for non-CLL, and so it makes a difference sometimes in our reimbursement. So we may have a slightly wider definition if we want to treat someone with effective therapy to their chronic lymphoid leukemia if it's typical clinically. Although I agree, it's very rare to see CD5 negative CLL. I can't remember a case recently.
As we all know, CLL diagnosis criteria rely on morphology and immunophenotype. Those are actually pretty important for CLL diagnosis. But differential diagnosis remains a difficult issue in some small proportion of cases. Some require markers including CD5, CD19, CD20, 23, kappa, and lambda. And some recommended markers, including CD43, CD200, CD81, ROR1. So, are also important. So, we tell us in which circumstances CD43 and CD200 can help diagnosis of CLL. Thank you.
I may start. I was looking up again the ERIC recommendation panel that was established and done with, let's say, a consensus panel of markers that contribute to the profile of CLL. And as you are aware and have said, CD43 and CD200 can contribute to the phenotype. Personally, I have to admit, I don't look very much at these markers, but that's maybe because our lab is doing this way. We are contributing in all the ERIC harmonization trials, but for us, when you have a typical CD5 positive B cell marker, so for example CD19 positive CLL, which has a restriction of kappa lambda, and then the genetic phenotype of a genetic aberration that is typical for CLL, the discussion and the diagnosis is done. And that's so often that I don't have to add many more markers to establish a diagnosis more reliably. So therefore, I don't put much emphasis on CD43 or CD200, at least in my clinical practice. But I would agree that they can contribute to a typical CLL profile if applied properly.
I might comment because I agree. I have the advantage of working with Andy Russian, who put together the ERIC panels and did the survey, and these are antigens that are widely used but not universally used. I find in the diagnosis that CD200 is a very good antigen for CLL. It's very unusual to see a CD200 negative CLL case, and so I tend to look at, as well as the conventional markers, CD200, and I find ROR1 as well being a very useful marker, and we get that in all our cases. So they're usually positive in CLL cases. I don't use CD43 personally, but I know Andy does.
I agree with both Professor Hallek and Professor Hillman, and it's not immediate taking my attention CD200, although it is in the flow panel that we have for B-cell tumor diagnostics, leukemic B-cell tumor diagnostics. But when there are some atypical phenotypes, atypical markers, then I start looking also at the expression of CD. Pay attention on what the people of the lab are reporting about CD200. Although it's not, it is very useful in differentiating CLL from mantle cell lymphoma. From my clinical experience, marginal zone lymphoma either it is expressed in other leukemic situations, for example, hairy cell leukemia, but in that case, the phenotypes are so completely different that there is no doubt that we are dealing with one or the other one.
Okay, thank you.
I'm
may I ask a question? Will MRD get the choice of targeted drug therapy in the future? Please.
Maybe I could start with this one. So I believe that we are now getting a lot of different choices of therapies, as I described, and I think it will come down to the aim of therapy and whether we are trying to eradicate disease or not, i.e. fixed duration or continuous treatment. And I think in many patients we will be moving towards a fixed duration treatment and stopping therapy because the combinations of targeted therapies are well tolerated. So even in the more the frailer and more COVID patients, I think it's becoming possible to combine therapies and eradicate disease. My bias is that we will move towards a guided approach with MRD because we see, certainly in the combinations of novel agents, different speeds of response. And so I think MRD will become useful to guide the length of therapy. I think we do need to do some more work, and we are doing more work on the tissue because we really have to be able to look at peripheral blood if we're going to use it as a dynamic guide of therapy. And for most therapies, certainly with those without antibodies, I think the peripheral blood is usable to guide therapy for the most part. So I think it's clearly a very important prognostic a marker for therapies that eradicate disease at the moment, and I think in the next few years will be used to guide therapy.
I would fully agree, and maybe add one short sentence. I think we need to wait for the targeted agents, whether MRD is really predicting long-term outcome. So while I'm a strong believer in this concept, meaning that achieving MRD negative remissions by combinations of novel agents may actually predict long-term outcome or survival, it remains to be formally proven. And we are looking and eagerly waiting for more analysis of all trials, including our own, to see whether that can predict long-term survival, as it seems to predict long-term survival in chemoimmunotherapy trials. But this said, I think it will be a major parameter to guide our treatment concepts and the duration and intensity of the therapy in the future.
I agree, Michael. I think that you're right. I think we have evidence now in the targeted therapy arenas, for example, in Murano, that MRD predicts for outcome. But the key question we don't have, and we don't have much evidence for at the moment, is if we take an MRD positive patient and make them MRD negative, does that have a difference in outcome? So should we be using it to guide therapy in that way rather than predict outcome? And I think that's the piece of the jigsaw that's missing.
If I may add a final comment, I think that MRD is relevant in therapy according to the therapy context or not, because if we are considering as therapy continuous BTK inhibitor a continuous BTK inhibitor approach, in that case I would not use, of course, MRD for guiding my treatment choices. And while in my practice, coming to the clinics, I'm now using more and more to check the MRD status after every fixed duration approach containing venetoclax, just to have an outlook on the quality of the remission at the end of the fixed duration treatment shot, and have a sense also during the discussion with the patient on which would be the outlook in terms of risk of, let's say, immediate bracket or later time to progression.
According to the MRD, I think it's very interesting. Just like mentioned by Professor Hillman, in the talk, at the end of the CLL14, we only achieved 58% of MRD negativity, but if we prolong the two drug combination, just like the protocol of MD Anderson Cancer Center, after 24 months treatment, the MRD negativity can increase to 80%. So, what the optimal duration of the new combination, and also as the reported by the the 3-log decrease of the MRD detection after 2 cycles combination will predict the outcome after 24 months combination. So it's very interesting. If we cannot achieve MRD activity at the month 26, we will still continue at ibrutinib. But we already have the monotherapy of ibrutinib study. We can achieve a very good disease control if we just stick on the drug. So can we have the some study to switch if we cannot achieve 3-log decrease after 2 cycles? Can we switch to the monotherapy of ibrutinib? And also, we just talked about the drug holidays when we have a meeting this morning. So, after the CL14 study, only 12 months combination, we just stop if we cannot achieve undetectable MRD. We still stopped the study, still stopped the treatment, and until the next progression, we will start our new treatment. Do you think the drug holiday will benefit for all the patients? Maybe we only need 12 months, not only for those undetectable MRD disease, but also for those detected. Okay, thank you. A little bit complicated.
We can probably answer all 3. I start because you speak about CLL14. Just to say that we think we have a little higher, but you can speculate because our rates of bone marrow assessments are a bit lower. Yet the overall MRD negative patients in the peripheral blood, which is different assessment, of course, are higher, around 80%. But the key thing is, we don't know whether achieving an MRD negative remission or having a shorter treatment is of any benefit, and whether you continue, you achieve more. So I would say that's exactly why we said it remains to be proven whether these longer therapies to aim for MRD negativity after, for example, 2 years are doing any better than the short therapies. And the only thing we feel that it might be beneficial is that you stop therapies at some point, and that may actually allow you to prevent clonal evolution under therapy, and then you can restart therapy when you have a remission, because it usually works. So that's our feeling. So it's not wrong to stop therapy after a year, and it's also not proven that you have to have an MRD negative remission to gain optimal benefit for these targeted therapies, at least based on the data that we've had so far on the combinations. Yeah, so that I will leave it at that for the moment.
I agree. Just to add on to that, I think the fixed duration, whether it be 12 or 24 months, depending on the disease status, perhaps or frontline, it's not a fair comparison to continuous therapy, because you have to see if patients will respond again to the same therapy. So you really should be considering failure of that type of regime if you're going to repeat it again, rather than it's not a fair comparison to a continuous therapy. Just to pick up on 2 of your questions. First of all, my thoughts are that in the patients, if we can separate the patients early on in the treatment course, say after 2 or 3 months of treatment, to predict which patients will achieve MRD negative remissions and which won't. Rather than de-escalating the therapy, I think you may escalate the therapy in those patients who aren't going to achieve a deep remission, to try and move them to a deeper remission, maybe adding antibodies or whatever. There are several other drugs you could add. So that's the first thing. And then the second thing, in terms of drug holidays, I think that's a really good question because, for example, in a continuous BTK inhibition, of course, we have this paradigm that we treat until disease progression, but that was based on initially 2 or 3 years of treatment in the RESONATE-2 trial, now 6 years of treatment. So we have very few patients who have had treatment for beyond 6 years, and so we don't have any evidence that actually giving the treatment for 10 or 20 years is the right treatment. So we are just about to start a trial called STATIC, where we randomize patients who are in good remissions on ibrutinib for a period of time to intermittent treatment as opposed to continuous treatment, to see if we can reduce the clonal evolution, as Michael said, and say BTK mutations. And there's evidence in other cancers that approach with continuous therapy is much more effective actually in controlling the disease, because you allow the wild type disease to control, if you like, mutated disease. So I think we need to really examine stopping therapy in appropriate trials before we do it, obviously, in clinical practice.
Thank you.
For the previous 2 questions about how to use the CD43 and CD200, and that's my question, because last year there was 2 consensus has published the ISMO and the FINO criteria, CL diagnosis criteria has published. And this FINO criteria, it say that if the score is 3, and we can exclude the mantle cell lymphoma, and if the patient has one of the CD43 or CD200 positive, then we can make the diagnosis of CLL. So I think this FINO criteria is very useful. It can get our clinical practice. So I mean, do you guys agree with this criteria? That's very useful. I think that's useful than the ISMO guidelines. That's my question. I mean, if this patient only 3 scores, then if there was one of them was positive, can we have the confidence to diagnose the CLL? In your opinion?
I think, as David said, you have to exclude the other diagnoses when there's atypical in the phenotype. When you have a very typical phenotype, then you don't really need to chase mantle cell or marginal zone lymphoma or the other diagnoses. But I think if you don't have a typical phenotype, then you are obliged to exclude them with, mutation testing and biopsies and another tests to exclude. And then we are left certainly with a group of patients that we don't know how to characterize with a CD5 negative LPDs, or we would tend to call them rather than CLL. But I'm interested in other people's thoughts.
I'm not sure whether I fully understood the question, but I want to emphasize, because there seems some uncertainty how to correctly establish the diagnosis of CLL, in particular if you have a CD5 negative case or some questionable parameters, and repeat both what Pete said and what I said before. I think if you have a suspicion that this is not a typical CLL for whatever reason, including CD5 negativity, I would maybe expand the panel of markers that you investigate, like you said before, CD43, CD200 or whatever, but more importantly, I would then proceed for cytogenetic examination and see whether you find a typical deletion or aberration for CLL or some other markers that are making the diagnosis for for example, mantle cell, where you have translocations that are quite typical. And next, if you don't do that, if you can't find anything like that, I would try to proceed to a normal histopathology exam of a lymph node if you get one, because very often that allows you to rule out a number of other entities. And with these 3 steps, cytogenetics and then histopathology, there remain only very few cases of atypical CLL. So I would like to emphasize this workflow with patients that have a untypical presentation or atypical presentation of a CLL case. I hope it was answering your question, though.
I have a question. So regarding the MRD, I think the situation of the CLL is something different with, for example, acute leukemia. For example, in ML, the negative of the MRD negative means the tumor burden is really reduced significantly. But if we check the bone marrow MRD is negative, it's not necessarily mean it's actual deeper remission in addition to the bone marrow, for example, in lymph nodes, also other extramedullary lesion. So what's your comments about the MRD view? Is it a surrogate mark for good prognosis? So in addition to the MRD negative, do we need other extra examination to help to confirm the prognostic value of this negative MRD negative? So my question is, it's possible the bone marrow negative MRD negative can be used as a surrogate marker for the CLL.
Shall I start again? So I think what we are talking about here is MRD in clinical trials, where it is a very useful surrogate marker for the efficacy of the regimen, to allow to make distinctions between one versus the other. In particular, if you when you investigate targeted therapies and wish to compare 2 arms that have a similar duration but have different drugs. It may also allow you to terminate treatment in trials, not maybe in practice, but more in trials. In clinical practice, MRD is still not a fully established marker to make treatment decisions in most cases. So if you do a 1-year combination therapy with, for example, venetoclax or obinutuzumab, as you have proposed, because that's the standard that has been published, or a 2-year regimen with venetoclax rituximab in the 2nd-line therapy, according to Murano, you don't need MRD assessment to make the decision to stop or not stop the therapy. There's one exception in my personal approach to patients. If you have a high-risk situation, which means P53 dysfunction or a complex karyotype plus P53 dysfunction, in these patients I tend to actually go further and try to get to MRD negativity with combination therapies. That's a personal style. However, here again, we have learned that it may not be essential, because the trial and data that Peter Hillman just showed by Adrian Wiesner, the paper in the New England Journal last year, shows you that if you have a continuous therapy with ibrutinib in these patients without any MRD negativity, you have a very, very good outcome. So in summary, I would emphasize that MRD for clinical practice right now still has limited impact on the therapy guidance. It is a more important marker for therapeutic trials. I think that's a very important distinction to be made.
I would make a comment. I'll make a comment. Yeah, I'll make a comment about the MRD question you just asked. I agree, and I think there are MRD in any disease that I'm aware of predicts for outcome, whether it be acute leukemia or myeloma, CML, CLL, which is no great surprise, of course, that the deep remissions do better with most therapies. There are differences. You brought up AML, but some diseases you need to look at the marrow because of the distribution of the disease, whereas in most times CLL is more distributed, in my opinion. You have to be aware of the therapies, because some therapies more effectively clear the blood, and therefore the blood can be negative, and the marrow is often positive. Campath was a great example of that. In some diseases like AML, a relapse of MRD precedes a clinical relapse by a matter of days or weeks, whereas in CLL it can be months or years, and so it gives us more information about the dynamic of the disease. In terms of other modalities to assess the patient, I think we're really struggling in CLL with the overuse in many trials, and I would say almost abuse of the use of CT scans, and they don't always predict for outcomes. So we saw in Murano, for example, 9 months, many patients are MRD negative, but they have residual lymph nodes, and we don't know the significance of that. So my opinion is that the clinical parameters, including blood counts and MRD in CLL, are a much stronger predictor of outcome than a slightly large spleen on a scan or a slightly large lymph node. So I think we try to address that, and Michael read, of course, the guidelines, try to remove the requirement to do regular scans in real world and clinical trials, but it's been a challenge, I think.
Let's move to the next question. There's another question, maybe always happening. Sometimes we are happening in China and other countries, because there's so many BTK inhibitors there on the market, and somebody will switch ibrutinib, for example, to the other BTK inhibitors. So do you agree in which situation you can switch? In which situation we should not switch? For example, for the progress disease, to switch, or if the patient has some side effect happen when you use ibrutinib, for example, the atrial fibrillation, and then can we have the confidence to switch to other BTK inhibitor, for example, acalabrutinib? What's your opinion? Thank you.
I try and address that. So I think we have to accept and we have to acknowledge that ibrutinib has been a drug that has had a massive impact on the survival of our patients. Obviously, venetoclax came a bit later, but the drug is generally very well tolerated and very effective for certainly in frontline and in relapsed CLL. There are obviously some concerning side effects for some patients, particularly cardiovascular type side effects and some nuisance side effects that we see in a minority of patients. At the moment, I don't see the comparative data that will allow us to move all patients over to the next generation, as they're called, more selective BTK inhibitors. There is data coming out later on this year for the first head-to-head comparison in CLL, which will be interesting, and it may be that there are groups of patients we would prefer to use a more selective BTK inhibitor in, such as those with cardiovascular disease, where the risk might be greater. I think at the moment it's too early to consider switching all patients. However, patients who have arthralgia or significant nuisance side effects, then it's reasonable to consider switching them, because some of those side effects are better. That would be my opinion at the moment.
Nothing to add from my side. I think the current situation is that with the other BTK inhibitors, we have a little less experience, and only the head-to-head comparisons will really allow us to judge. There is some data from other entities, though, that indicate in Waldenström's that acalabrutinib may have a little less toxicity, in particular in the cardiovascular system, and maybe a personal style that I just can share is whenever I have a patient that is doing extremely well with ibrutinib but has cardiovascular problems, I try now to switch to acalabrutinib and see whether he's doing any better, just to try out. And sometimes it works, sometimes it doesn't. So just as a short addition to what Pete said.
My personal approach is exactly the one that you said, Michael, because I'm now with the availability of acalabrutinib, I'm considering that whether there are cardiovascular risk factors before starting therapy, and if I have some concerns, I would prefer using acala than ibrutinib. And the second situation in which I use the second generation BTK inhibitor is when there are some clues of intolerance without any sign of resistance or progressive disease. And in that case, I try to reach in order to mitigate the side effects. So, although in my experience, sometimes they are overlapping, so they represent again with the second generation BTK inhibitor.
The last question. Yeah, for now, the chemoimmunotherapy may still be considered on the appropriate first-line therapy for a fit patient with IGHV mutated. In the patient with IGHV unmutated, due to the disappointing results of chemoimmunotherapy, continuous BTK inhibitor is the best option to date. Now, my question is, are you then treating all unmutated patients with novel therapies, or would you start chemoimmunotherapy and switch early in the case of the poor response? What is the optimal therapy for patient with IGHV mutated patient, FCR or targeted therapy?
Well, I have a question to Michael, just to engage the discussion. Do you feel that in this subgroup, Ven plus G would be the next FCR, and in the first line therapy, in IGHV mutated patients?
Good point. I would say there's still some differences and difficult to predict. I would say yes. In my gut feeling, it could be replacing it. I'm eagerly waiting for the head-to-head comparison with all conditions. But yes, and to the point of the question, I don't treat unmutated patients with chemoimmunotherapy anymore, except in clinical trials, and there are no more trials open in Germany. So for the mutated patients, I still, in some patients that have a positive, or let's say a good prognostic cytogenetics, I sometimes discuss the potential of a curative therapy or long-term remission with FCR. It's rarely is chosen, especially now in times of COVID-19 in Europe. But in the unmutated patients, as the question is posing it, I usually try ibrutinib, in some patients also venetoclax or venetoclax. Although we don't have the label, we have the label, yes, we can do it, but we don't have the evidence yet for young patients that it's better than FCR or better than ibrutinib. But my personal selection is in unmutated patients to no longer use chemoimmunotherapy.
I can address it from a UK perspective. I don't think there's any argument about unmutated disease. I don't think you should be exposing them. patient to chemotherapy if you have availability of targeted treatment. I think for the mutated patients, I think there is a decision because, as Michael mentioned, probably a third to a half of patients may have effectively a cure or prolonged remission, but we will damage some patients, both the disease and the underlying marrow. And so we're having a discussion with patients in the UK, and I've not had a patient yet want to have FCR, even though there's the possibility of cure. So every patient has chosen to go down a targeted treatment route since we've had it available. So I think scientifically you can make an argument for using FCR, but I think emotionally patients don't want to have it if they don't have to have it. And I would agree, because I think probably 3% of patients will develop secondary MDS AML, and that's fatal without a transplant. So I think it has to be, you have to bench that to patients. When it comes to choice, I think the evidence is leaning, but we have big trials coming, the GEM 13 trial, the FLIR trial coming out, and that will I think really define it more. But I think I'm leaning towards Veno being the best treatment for mutated disease, because it's clear from CL14 most patients are in a durable remission and then will probably respond, and that the unmutated patients probably are better treated with a BTK inhibitor, but I suspect it will be a combination of venetoclax and the BTK inhibitor will be better for those patients, looking at the MRD responses with that combination for unmutated disease, which is actually better than for mutated disease if you look at the studies. So I think we're going to be using mutational status to decide which therapy to use.
I'm not sure about this, but that's because you're treating longer, and if we treated this group 2 years with venetoclax or obinutuzumab, it might be a different result. So this will be seen, but that remains an open question for the trials that we are analyzing in the next few months.
It wouldn't look good if we agree with everything, Michael.
Yeah, it's exactly true. Yes.
Thank you.
Any more comments? So, thank you.
David, you can give your opinion on treatment.
Okay. For this question, in our practice, for the young and the mutated patients, I think maybe FCR is more optional, because most of the patients can get a very good response and stay free digit maybe for 3, 4, 5 years, and so it is cost effective regimen. So for also maybe we can combine the FCR with the BTK inhibitor to get more patients can get deep response, and can reduce the maybe reduce the circle of FCR, and then will be more tolerance. And for the unmutated patients, now we try to combine the CIT with the BTK inhibitors together. Then more of the patients can get better and deeper response, and maybe we can switch to the long-time, maybe lifetime therapy to time-limit therapy.
I'm not sure. There's data from both the French and from the MD Anderson whether we have sufficient solid evidence to say that IFCR is a better option than anything else. You may increase the responses, and the data have certainly been encouraging, but there was also a bit more toxicity. So if you wish to save costs on drugs or so, I can understand why you are trying these things, but then I would still not really see a benefit of IFCR versus FCR, at least from the data that I know. So maybe the two other persons on the panel can comment, but I'm never using IFCR for anything right now. That's a personal selection that is based on a lack of evidence that this is any better compared to the other drugs.
Yes, I agree, because the data are limited, and I also don't have a full sense of which would be the increasing toxicity of this combination, and therefore I never use PTK inhibitor in combination with any kind of immunotherapy. And I'm no longer using FCR from a while because of the emotional comments on aspects that Peter was mentioning before when discussing with the patient the treatment options. And second, because actually, at least in my clinic here in Ticino, it's pretty rare to encounter a first-line patient with IgG mutated status and young and fit enough to be considered for FCR.
My opinion in the combinations is that well, we're in a very privileged position of having a lot of new therapies that we need to examine. I would think actually, if we're going to use chemotherapy in combination, a more logical thing to combine with is venetoclax because of the mode of action, and probably using less intense chemotherapy than FCR would be sensible. But I think what we can all agree with is we need these regimes to be studied in well-designed phase 3 clinical trials, and we need to all be working together as an international community to make sure that our trials can all be interpreted using the guidelines as appropriate and comparators that are appropriate, so that we actually, there's enough clinical research that large groups like your own and the German group and our group and the American groups, etc., can do meaningful trials that will move these questions forward quickly. I think ibrutinib or BTK plus FCR is a legitimate regime to test in a clinical trial, but certainly not, as I agree with David and Michael, not to be used outside of clinical trials.
Okay, because the time limit, and we'll close out this session here. Thank you for your joining us and give us a lot of opinions and knowledges. And we hope that COVID-19 crisis will overcome and soon. So then we can come together and communicate in person. Thank you. Then we'll take a picture with you. Thank you.
Thank you.
Welcome. Thank you. Bye.
Please hold online, and we will take picture together.
Okay.
Thank you for your interest and for having us, and I enjoyed the interaction. Hope we meet soon.
Well, and I just to finish from an IWCL perspective, we very much appreciate the collaboration with the Chinese group, and hope that it continues to get stronger. Are we here alone now?
No, you tell us when we can leave. Pictures taken. I think it's okay.
Okay, thank you. Bye. Thank you.
Goodbye.
Nice day.
Bye, everyone.
Have a good weekend, Peter and Davide.
Yeah, have a good time.
See you soon.
Cheers. I'll show you all.
Bye. Bye.